total, do you know?
We've currently got 50.
Oh, okay.
And it's rising. So yeah, ready when you are. We are recording.
Everyone's introducing themselves in the chat and saying hello, which is lovely.
Brilliant. Okay, welcome everyone. My name is Charlotte. I'm Chief Executive at National Voices. We're the umbrella organisation for charities in health and care. We've started setting up this webinar series really to sort of check in more regularly with our members and to hear what they were doing during this crisis. And then it's sort of grown really quite organically into us fielding speakers and discussing set topics that come up from our membership that we felt needed further engagement and a bit of scrutiny. And that's how today's webinar came about. If you're a National Voices member, we all know the spiel by now. If not, if you're here for the first time, a very warm welcome from all of us at the National Voices team. We've got Sam looking after technology, Ella's looking after the chat. We've got Jess as our head of engagement and Rebecca was our head of policy. Then we'll talk briefly towards the end of the webinar. But most importantly, we've got two really interesting speakers. We've got first up Professor Kevin Fenton from Public Health England, who will talk to us about the work the government are kicking off to understand the disease burden of COVID on Black and minority ethnic communities. And then we've got Kadra joining us from Charities So White, who will give her perspective. If you are new to the whole technology we're using today, Sam will very briefly run through that now. I kind of assume you have used webinar technology by now, 5 weeks into this, but he will just briefly explain to you what buttons to push for what purpose. Sam, over to you.
Hi everyone, thanks for joining us. Just quickly say now we're recording this webinar and the recording will be available after we finish. WebEx is, if you haven't used WebEx before, at the moment you've got 6 icons at the bottom of your screen, one to control your microphone, video, and there's one where you can access the chat. That's where most of the contributions and insights and conversations are all going to be happening today. So if you could introduce yourself now, just launch the chat, which is the speech icon, and you can chat to everyone, and you can also chat to people privately as well. So yeah, that's kind of the 2 main points. I'll hand back to you, Charlotte.
Okay, so very briefly what we're going to do now. I'm going to give you very quick feedback on what we did last time, and then I'm going to hand over to our speaker. So you remember last time we had Freddie from MS Society talking about changes to community healthcare provision, where there were some concerns around the guidelines. I don't know whether any of you have reached out to Freddie, but she's still really interested to hear. Freddie at MS Society. If you don't have her email address, we can obviously make that happen. We are exploring whether to feedback to NHS England our concerns about how healthcare in the community is delivered and really quite some worrying cuts to some of that provision. Emily then spoke to us about a campaign, the Disability Benefits Consortium we're running, campaigning on increasing disability benefits by £20 a week to keep them in line with the increased rate of universal credit. And that kicked off this week, and I think that made quite a lot of noise on social media and got petitioned to Parliament and all that. You can obviously still support that. And then importantly, we talked a bit about our project, which we're now launching on Monday, which is called Our COVID Voices, which is our attempt at National Voices to help surface people's experiences of COVID and their lives during this crisis, particularly people who live with ongoing health and care needs. We think whilst there is an unprecedented interest in health policy, the voices from people who actually have substantial health and care needs and had them before COVID and will have them after COVID are sort of curiously absent from the debate. So Our COVID Voices is a web platform where anyone can provide first-person accounts of what actually goes on, and we can do this over time, and we can check in with people, and we can explore specific experiences in more detail. We've got about 8 or so stories already, which we just sourced through our personal networks, and quite a few of those people are people who are shielding, which has really opened my eyes to what goes on for people who are asked to really live with very draconian restrictions on their freedoms. So that's going to launch on Monday. We want to start quite a big comms campaign around that on Monday. It'd be wonderful if you looked out for that. and supported us where you can, and share it with people who might want to tell us their stories. We're going to take all this insight and data and take it to decision makers, for example, around the decision whether shielding should be extended or not for certain groups. So that's where we've got to since the last week. We've all been stupidly busy. I'm sure you all are very busy, so we're really grateful you're making time. Let me just ask, is there anything on the chat I should talk about, Ella, or can we go straight into the substance? I think we're still on the introductions.
I think if we go straight into it, Charlotte, we just had the introductions.
Cool, excellent. So, Kevin, I don't know whether we've sorted your camera or whether we just have to do with your voice, but either way, we're so grateful you were able to join us today. Professor Kevin Fenton leads the London region for Public Health England and has been asked to also lead part, I think, of the work on the burden COVID causes for BME communities. But you could probably better explain how that all hangs together, Kevin. So over to you.
Wonderful. All right. Thank you very much, Charlotte. Can you hear me? Can you confirm?
Yes, very clearly, yes.
Fantastic. Great. Good morning, everybody. I hope you are all well. It is a pleasure to be here with you this morning and a real fantastic opportunity to have this conversation with National Voices today. I am, as you heard from Charlotte, the new Regional Director of Public Health for London, and that's a joint position. So I'm actually the RDPH for PHE's office in London, but I'm also NHS London's Director of Public Health as well. So I have a joint appointment between both agencies. This reflects the new footprint for health and care across the country. So you have more integrated public health senior leadership at the top of NHS regional offices. But it also reflects, I think, the movement more generally of greater working between local government, the NHS, public health, and of course, community partners. So it's within this context then that I start this job, and clearly the other context is starting in the middle of a pandemic. And in the 3.5 weeks that I've been in the job, it's been a really important and interesting time getting up to speed with everything, really driving through the key elements of Public Health England's contributions to epidemic control. So whether it's data and surveillance, producing guidelines for the system, really helping to coordinate. Certainly in London, I've taken a lead for coordinating the availability of testing and developing our strategic approach to testing. In the next week or so, contact tracing is certainly going to be moving up the agenda. But more importantly, as we think about the removal of lockdown restrictions, that's certainly going to be a big part of our work in Public Health England as well. So I wanted to start with a little bit of context about myself and about my role before going into the specifics of COVID and BAME. And I'm going to end my update by just giving a little bit of a reflection on why this conversation is important to me and what I hope to build as I start this new RD role, Regional Director role for London. And one of the key priorities for me is to have a strong relationship with our community sector. Because now more than ever, and in a post-COVID world, we are going to have to seriously rethink the role that communities, voluntary sector organizations must play for our society and our economy to get back on its feet. So I'd like to end my brief introduction with a little bit of personal reflection on that and to reinforce that you do have a champion in me when it comes to supporting the community response and the community resilience. All right, so let me just give a few points on COVID and Black and minority ethnic communities. Since the emergence of the epidemic in China and as it has moved across Western industrialized states, it has become increasingly clear that not only does COVID disproportionately affect certain subsectors of the population, but in areas where there are significant disparities or where there are significant populations and communities at social or economic exclusion, that COVID tends to both spread quickly, but also to have a disproportionate impact on those communities. So whether it is most recent reports coming out of Singapore, where you're hearing really harrowing stories about the COVID epidemic becoming hyper-endemic among migrant workers who've had poor access to services. In the US, the disproportionate toll on African American and Latino communities. And certainly here in England and in the United Kingdom, over the past month, it's become increasingly clear that minority communities are disproportionately affected, visibly so when NHS staff are represented on television, and you see not only how much the NHS relies on BAME staff, especially not at the executive level, but at the grassroots level. And certainly in reports which are now beginning to be published, looking at various aspects of the clinical pathway, we're also seeing Black and minority ethnic groups being disproportionately represented. There's a recent study looking at severe cases of COVID nationally across the United Kingdom and mortality, and it really suggested that Black and minority ethnic groups were disproportionately represented in ICU admissions and severe disease. So that's the sort of context in which we've seen the pandemic and how the pandemic has spread over time and how it becomes rooted in and affects particular community subgroups. Now, in England, as well as the developed nations, this issue of a disproportionate disease burden on minority groups has risen up the political priority list. It's not the only disparity we see with COVID. COVID incidence tends to be higher in older individuals than younger individuals, and the disease is more severe in older individuals than younger. In men, we tend to see more severe disease in men than women, and mortality in men than women. If you are a smoker, and if you are obese, you tend to have worse clinical outcomes and are more likely to have severe disease, and some suggestion that it may be a risk factor for mortality. And finally, if you have multiple long-term conditions, especially kidney disease, uncontrolled hypertension, and poorly controlled diabetes, these are all seen as risk factors for severe disease and death. So the question that's being asked in England is, do we see differences across racial and ethnic groups when it comes to COVID and all parts of the clinical pathway? Are they minority and ethnic groups more likely or less likely to get tested? Are they more or less likely to be diagnosed? Are they more or less likely to have severe disease and be admitted to intensive care units? And are they more or less likely to perish from their condition? And so in a nutshell, that's the review that Public Health England is undertaking. It is looking at the epidemiological data, health services data, and a number of other routine data sets, which we are linking and combining to get as complete a picture as we can on the pathway, the clinical pathway, and its relationships to race and ethnicity. Now, by linking those data, it means that we're able to bring in a number of key factors which can influence outcomes. So part of the work is doing what we call descriptive epidemiology, which is just describing what we see and the patterns that we see, and we'll be able to do that across racial and ethnic groups, geographic area of residence, etc. And then what we'll also be able to do is multivariate analyses. In other words, controlling for factors which we know drive severe disease. Does that explain or does it mitigate the relationship between ethnicity and adverse outcomes? So, for example, if we control for age and gender and multiple long-term condition history, for example, does that explain the variation that we see across the ethnic groups? Now, in some studies, there are signals that this is indeed the case, that actually quite a lot of the disproportionate burden that you see is because people are coming into the healthcare system with different pre-existing conditions and other demographic characteristics which put them at higher risk. But PHE's review will be the most comprehensive, and it will be able to answer those questions, I think, definitively. So I think the key thing for all of us as we do this work is to approach it agnostically, not going in with any preconceived ideas about what the relationships are, and being open to being surprised, because it may well be that even after controlling for some of these social and economic factors, there may still be differences. Or because many of these factors are socially dependent and socially contingent, it may also be challenging as well. So in other words, smoking is highly clustered in lower socioeconomic status communities. Obesity is also highly associated with your economic well-being as well. So again, rather than trying to preview what we're likely to see, I've been encouraging colleagues to have an open mind. The second part of the PHE review is to look at a series of stakeholder engagement and listening sessions, which we started last week and continue this and next week. And essentially what we're doing here is looking at opportunities to bring in a wide and diverse range of stakeholders to both reflect on what they're seeing and hearing and feeling about this issue, and to begin thinking about what's being done locally and nationally by other partners, and finally to agree what are the things that we need to do and above and beyond our efforts moving forward, especially as we move into this recovery period. The COVID issue and BME is not just a data issue. It's a hearts and minds issue. It's an emotional issue. It's an issue of fear. It's an issue of distrust. And so I was very clear when I took on this role that not only will we deliver the analyses, but we need to hear the stories of communities, and we need to engage people, because how we frame those results will determine how well they land, and how we work with communities to prepare for the results and what we do differently moving forward is going to be critical as well. And I say that moving forward because whether we expect a second peak or not, all of the things which are coming up in terms of managing COVID, if not managed well and if not managed immediately through an equity lens, will widen inequalities and worsen the experience for minorities in future phases of this outbreak. So let's work through that. If testing is not scaled up in an equitable way, with resources for people who don't speak English, with barriers removed for people with uncertain migration status, you won't test people who need to be tested, and that may result in a concentrated disease transmission. If you are not supporting people to social distance, to wear face coverings, to do all of the other things that we know works, that means they're less likely to be able to do those things, and again, placing themselves and their communities at risk. So we can't think of equity as an add-on as we move forward. And I would encourage us to think about how we build equity in to the things that we're doing for COVID. And as we restart the NHS, restart social care, we must be asking ourselves, now we know better, what difference are we going to do when it comes to equity? So my final point then builds on that, and that really is why I think this conversation is important and why I'm keen to work with you today. It is absolutely critical that I have 4 key pillars in terms of my leadership in this role. The first is obviously working with the NHS. The second is working with the local government and City Hall. The third is really thinking of academic partners and having a much more strategic, balanced portfolio of research that actually matters to practitioners in the city. I'm very passionate about implementation science and program research that helps us to do things better at the local level. But the fourth pillar of my partnerships will be communities, because if we're going to be successful with COVID moving forward, we have to have trust. And we have to bring communities with us. And the data are showing where communities don't trust, then they're less likely to take up the measures that are being proposed by government, whether national or local level. And you guys know how to build trust because you're in and of the communities and you represent and you advocate on behalf of the communities. And that's critically important. So I've been working through how best to do this. As you know, this is perhaps an area that PHE isn't traditionally been in. But as the new RD, I'm keen that maybe that will be a new way for us to work, a new way for us to think about our system, and a way for us to be far more inclusive. So I will end there. I hope that's helpful to get us started today.
Very helpful. Thank you, Kevin. And thank you for signalling so strongly that you want, this is just sort of the beginning of this engagement, and that there's many people we need to reach in order to get to the answers and the solutions, and that you are willing to put the effort in to make that happen. That's really good to hear. There's quite a few questions that have obviously popped up. Someone's asking, is there terms of reference for the work you're doing, which would be really useful, I think, to share, as those have been pulled together by now, and maybe in sort of connected to that, what we would really need to understand, I think, is where your review sits because there's like a plethora of stuff now happening, isn't there? There's work being kicked off, I think, by Prarana Issa, who's the people director of NHS England, more with the workforce view. And then is there work that the government is leading on? Could you explain to us the architecture of these various strands of reviews? That would be super helpful. Thank you.
Sure. So there is the PHE review, which we're looking at. And just to say that we are starting with Black and minority ethnic communities, but we'll be looking at other domains of inequalities as well. And that work is going to be happening over over the month of May. There's an NHS-led strand of work led by Simon Stevens, and he's pulled together a group of internal and external colleagues to look at the NHS data and advise on actions. And you will see quite a number of communications coming from the NHS, I think, recently about the importance of this issue, protecting vulnerable staff, etc. So those are the two strands of work. But as you rightly say, Charlotte, there are other academic units who have been off the mark quickly, who are looking at the data. And there are a number of papers currently circulating which are confirming, certainly at a descriptive level, the variation in incidence by racial and ethnic groups. And some are able to be looking at some of the key determinants of that. So you have two reviews, NHS, PHE, and then you have academic institutions in this space. As you know, there are other reviews which have been called for. I think the Labour Party has asked Doreen Lawrence to oversee a review. We've spoken to that team so that they're aware of what we're doing. And one of the things I'm trying to do is to link all of the researchers that are working in this space so we can begin to share information as well.
Really helpful. I don't know whether Jabir Bat is on the call. Jabir, if you could just make yourself known, because we thought you might want to also kick us off with some questions.
I think Jabir is having technical issues, Charlotte.
Oh, okay, no worries.
That's okay. Sorry about that.
Well, I'm going to ask a question then that has come up on the chat, and that also occurred to me as you were talking, Kevin. We hear that all the time now, that people are saying, oh, we need to work with communities and we need a new deal for working with communities. And, that you said we as community groups have the trust of communities and therefore you need us and all of that. And that's obviously great to hear, but you also be aware that the community groups and the charities are under so much pressure financially now, and that we, I don't have the data for that, but we can make quite a safe assumption that those who represent BME communities will be particularly hard hit, and that, we face all these demands for, collaboration and leadership, which is obviously wonderful, but our funding has completely collapsed because we can't do community fundraising, and the government's furlough scheme doesn't work for charities, and the money made available by grants doesn't reach the communities who need it. So if this is anything you could take to central government to say, we can't layer on the expectations without recognizing that the VCSE sector is really struggling, and a lot of organizations are at risk of folding really quite imminently, that would be very helpful.
Charlotte, absolutely. And, having worked in local government for the past 3 years before coming back to Public Health England, it's clear that a lot of the challenges that you've described predates COVID. And COVID simply has come in and is sort of accelerating the decline, accelerating the challenges that community organizations face. So in the aftermath, as we are looking at rebuilding, I'm very keen to support and to lend my voice to the importance of maintaining this community infrastructure. Because one of the challenges I think that we have in times of crisis, we go back to stress behaviors, whether as individuals or I think as governments. And a key stress behavior for many governments is that everything has to be centrally controlled and commanded. Whether that has happened here, I'll leave that for you to describe. But getting out of this is a greater realization that we have assets in local government, we have assets within local communities, and the more that we can help to reestablish those assets, the better, deeper, and more robust and sustainable our response is going to be. And you're seeing some of this play out with the contact tracing deliberation going on now, where I think initial solution was national to local. And local authorities are saying, absolutely not. We know our communities. We know the communities that are less likely to take up this intervention. And we want to be part of shaping what that looks like for our people. So I think that's going to be a key theme. And it will be interesting to see how that dynamic of national to local working evolves. And I'm hoping that our experience with COVID will help to bring that realization that you do need that local infrastructure, of which the voluntary and community sector is a key part for us to get out of this.
Thank you. There's loads of questions. We won't be able to go through all of them right now. There's questions about faith communities, really interesting question about the volunteering program that's been set up by NHS England that required passport numbers and international driving licenses, which seems to have led to lower numbers of BME volunteers. There's even someone offering to, as a researcher, to join the effort. So we will obviously capture all these questions in the chat. We will share it afterwards, and we will also obviously share it with Professor Fenton. I'm just wondering whether we should now switch to Kadra, who could give us her perspective, and then we have more time for discussion after her short input. So please do keep asking questions and comments and thoughts on the chat, and we will make sure we won't lose any of this. But I'll hand over to Kadra now. And Kevin, if you have to leave, you know, we can understand that. But if you want to stay and hear what other people are saying, you're obviously very warmly welcome. Kadra.
Charlotte, I'd love to stay, but unfortunately I do have another call I need to jump on. But if you could send the questions, and I'd love to hear, I'll watch the recording of the person who's speaking after me. I'm so sorry I'm not going to be able to hear it.
Okay.
But if we
Thank
can,
you so much, Kevin, for joining us. Okay. And we will make sure that we record all the questions and share them with you. Kadra, do you want to take it away now? Thank you.
Great. Good morning, everyone. Sam, I'll just prompt you on the slides, if that's okay. And I hope everyone can hear me okay. Yeah, tough act to follow. So good morning, everyone. I'm Kadra Abdinasir from Charity So White. We are a group of volunteer grassroots activists who have been calling on the charity sector to take lead in rooting out structural racism. We are all people of colour who work within the charity sector and draw on our various areas of expertise. But I just want to preface all of what I'm going to say with the fact that, you know, we're not experts in COVID or in pandemics, but we have been really concerned about some of the emerging evidence and the headlines about the disproportionate impact on BAME communities. So in response to this, we produced a live paper called Racial Injustice in the COVID Response, and have set out a couple of asks for what civil society can do to respond to the crisis. We update this weekly, and we have a call for evidence for, you know, involving other people of colour and BAME-led organisations to feed in. And we review and update our recommendations weekly in line with key developments. So if we can move to the first slide, please. We like to do things in groups of 5, so you will see a bit of a theme happening here. So initially, I think it was about a month ago that we launched the paper, really drawing together all of the existing evidence around, you know, inequalities that BAME communities already face, and how the crisis is likely to magnify and further widen some of these issues. So I just wanted to talk through really briefly some of the key 5 areas that we identified. And I just want to be clear that even if we put aside the disproportionate mortality and morbidity rates that we're seeing with COVID, there are still some other areas where BAME communities will be, you know, most hit. And, you know, we don't need to kind of use the excuse, you know, the current outbreak is not about responding to the outbreak instead of addressing some of the racial injustices that we see. We do need to take a real intersectional approach. So the first one, in our paper, you will see that we've put together all of the existing evidence around health inequalities. As Professor Fenton mentioned, BAME groups are overrepresented in some of the key areas the government has already identified as people who are at risk of COVID-19. But we also know that BAME communities, you know, have had significant challenges accessing the support they need and accessing culturally appropriate services. So now we're just at this, you know, key point where all these sort of issues intersect for BAME communities. We also highlighted our concerns about some of the emergency measures that have been adopted by the government and some of the changes to legislation. For example, if we think about enhanced police powers to stop and search communities, we already know that Black communities are 40% more likely to be stopped and searched. So we need to ensure that, these emergency measures don't disproportionately and, negatively impact BAME communities. Another area that we've been concerned about is, the impact of the lockdown and the closure of schools on BAME pupils. So we've already seen, concerns about the use of predicted grades and what that is doing to the well-being of Black and minority ethnic pupils already. And, we're really fearful that we'll see a bit of like a widening attainment gap unless we take action to remedy some of these issues now. The third section is around risk of destitution. So we, as Professor Fenton mentioned, BAME communities are in, many localities overrepresented in key and essential worker roles, not only within the NHS, but they, are more likely to be Uber drivers, food delivery drivers, and if they're not able to work because they're unwell or, they've lost their lives because of COVID, their families are likely to be pushed further into destitution. The fourth area that we identified is, really starting to see the implications of the government's hostile environment policy, and particularly thinking about people with no recourse to public funds and undocumented people, and just how fearful they feel in this climate in terms of coming forward and seeking support. And the last area we kind of pulled together is around protection and enforcement. We've seen all the headlines about rising levels of domestic violence in the home. We know, again, BAME women are less likely to access those support services and are not able to access culturally appropriate services. And the lockdown is making, these support services even more distant from them. If we can move to the next slide, please. Drawing on lessons from past crises such as the Windrush scandal and Grenfell, we devised a set of principles to help guide civil society's response to the crisis. So the first one here about now is the time to address racial inequalities. Coming back to my point earlier, it's not a trade-off between responding to the crisis and tackling racial inequality. This is something that we need to put at the heart of our response. And that's something that didn't happen in the past, and a lesson that really came out of, previous inquiries such as Grenfell and Windrush scandal. The second one here around acknowledging the power you hold, don't distance yourself from it. We think there's a lot of power within the third sector and within the philanthropy and fundraising community. I think we really need to use that power at this time to empower and support communities affected by COVID. The third one here around actively valuing lived experience and those deemed to be at risk. It's our institutions inevitably that are hard to reach, not the communities we're talking about. And we really don't want people to be using the lockdown as an excuse not to engage communities. But it was really encouraging, I think, to hear from Professor Fenton that they're really keen to engage and really build in stories and narratives as part of their inquiry. So the fourth one here is about it's the time to trust Black and minority ethnic communities. We know that they often deliver highly specialized support and have lasting and trusting relationships with BAME communities. However, we were really worried to see that research published earlier this week by Ubele Initiative showed that about 9 out of 10 BAME-led organizations and charities are likely to close shop in the next 3 months, just due to the lack of funding and lack of historic funding. So we really do need to prioritize emergency funding for BAME organizations doing this really important work at this time. And lastly here, recognizing and supporting BAME staff and volunteers within the sector. We need to ensure when plans are being made to furlough staff within the sector that it's not disproportionately BAME, lower level employees and volunteers. We do also need to protect and provide, PPE to, some of our frontline workers within the sector. They mustn't be ignored as part of this. And we've already heard kind of worrying anecdotes of, charity workers working with vulnerable young people, for example, and not having access to that support. So both, the beneficiaries and the employees will lose out ultimately in this situation. Just to kind of touch briefly on some of the recommendations and what we're doing to drive forward some change in these areas. So our sort of short-term immediate focus is really trying to ensure there's equitable distribution of the emergency funding. So we've developed an open letter, which we can share with you after this webinar today. We've had over 90 signatures from individuals and organizations, including Equitable and Institute of Fundraising. And really within that, we have two key asks. One is that, the steering boards for these funding bodies and those making decisions about emergency funding involve two individuals who have expertise in racial inequality, so that they really can, advocate for the communities that we're talking about and organizations. And then the second ask we have is around ring fencing of funding. So we have proposed that around 20% of emergency funding that is being, developed by some of the big funders is protected for BAME-led organizations, because we're already seeing that they are struggling. And we need to ensure that the processes for them in order to apply are very streamlined and light touch where possible. We don't want people to be held up by bureaucracy and using that as a reason why they're not able to do the vital work they do. And just beyond that, I think it's often through crises that significant transformation and change emerges. So we really should use this as an opportunity to push for long-term structural change. Again, thinking about sustainability for the BAME sector within the charity sector, and thinking about, some of the long-term consequences of this pandemic. It's not just, coronavirus that people will suffer with in the here and now, but also thinking about, the likelihood of a recession and how that will impact the communities that we work with. Through our own work, we know that, for example, it's likely there will be, really a peak in, emotional and mental health problems because people have suffered, grief and not have been able to mourn in the ways that they would hope to with their family. So those are sort of some of the issues that we can begin to think about and mitigate against. So I'd like to end there, and thank you for having me.
Thank you, Kadra. Sorry, it's very compressed time, but really, really interesting points you raised. Just a couple of points straight away. We would obviously like, as National Voices, to sign your open letter about equitable access to funding. So if you could just connect with Jess offline, that would be wonderful. And just another connection to make is we are pulling together a response to this Culture, Communities, Media, Sport Select Committee about the impact of COVID on the charity sector. And it'd be great if you could support us to reflect what you've just said right in that submission, because I think it would be good to reference that point you're making in that submission, that we need to really keep an eye on equity and in trying to support the voluntary sector through all of this. Lots of questions like that also coming up in the chat. Has there been an equality impact assessment around the decisions around furlough and around funding decisions? Those are really good questions. I think we could also roll into our submission to the Select Committee. Questions around intersectionality. We've got someone here representing a deaf charity, and obviously there's all these things lay over each other. Is there Ella or Jess? Have I missed anything from the chat we should pick up now?
Charlotte, Rebecca Mansell from Sign Health putting some really, really good points on the chat. About how we should not forget deaf people who are from BAME communities. They face more barriers than hearing BAME individuals, and there's been some really good work they've been doing recently.
I know, making interpreters available for free to anyone in the NHS, which is just amazing. The kind of leadership is just amazing, and the money needs to be sorted quickly, but it's great that you've managed to just make that happen, Rebecca. But yeah, point well made. Anyone wants to say anything? You could unmute yourself and say something to Kadra or to the group.
Hi Kadra, it's Byron here from Healthy London Partnerships. Thank you so much. I managed to join a little bit late, but I think I got just the end of what you presented. The question that I had as you were going through was, I wondered how you came up with the 20% number or percentage for ring fencing the funding. I was just really curious about that. Could you share a bit more about how you came to that 20% figure?
Yeah, there's no real hard science behind how we came up with that figure. It's just a starting point for us. But what we have done is, looking at the evidence, 65% of BAME-led organizations, their annual turnover is something like 10K a year. So it's really a small amount of funds, and they may not be able to absorb the full 20% in response to the crisis, but we think it's really important that they have that sustainable funding to support their work on recovery. So it's a starting point, and we've had really productive conversations with some of the big funders, including the Lottery, Comic Relief. They seem to be quite open to the idea, so hopefully we'll have some positive news to share about that next week. So do watch this space.
Thanks, Kadra.
And thank you for joining us. I'm sorry you could only join us late. I think we had some technical difficulties at the start, which we can only really apologize for. Anyone else wants to say something?
Yeah, hi.
Speak up a bit.
Wasn't sure whether I was on mute or not. Hi, it's Ramsey here from Carers Trust. Thanks very much, Kadra, for that presentation. I think it was obviously really interesting. My question is, I think what COVID has done is sort of highlight the inequalities that have always existed, whether that's for sort of BAME communities, deaf people, disabled people, whatever sort of minority it is. I think we all know that they face massive barriers to accessing health and care before COVID, and what COVID has done is sort of brought that to the fore, to the point where decision makers are no longer going to be able to ignore it or push it to one side, or the other sort of approaches that they've taken to date. Is the post-COVID landscape more conducive to developing a better and more equal health and care system? And at what point should we start focusing on the post-COVID world rather than the immediate sort of need to ensure equality, ensure sort of equal access to health and care? Have you got any thoughts on that?
Kadra, whilst you think of a response, I certainly have some thoughts on that. I think, like, for example, National Voices as an umbrella organisation, we are not in the immediate response. It's our members who are. They're the ones whose helplines are running red hot, and they're the ones who have to transition their support offers into a digital offer. And, they find it very hard to think beyond the next week, although some of them are trying really hard to do that too. I think there's particular responsibility on the infrastructure and umbrella organizations to try to have a slightly wider horizon. So that's what we are definitely trying to do, is to think through what are the decision points at which we will either cement further inequalities into the new world, or we have a real opportunity to erode some of them. But Kadra, you might also have some thoughts on that.
Yeah, absolutely. I think we definitely need to be thinking about, as part of the exit strategy, the longer term recovery, how we can build equality within that. And I think what's really interesting to see is, in the middle of this crisis, all of the things we thought would be impossible are now happening. So if you look at all of the changes to the social security system in terms of protecting employees, who would have, ever thought this government would introduce such measures? And I think it is really highlighting all of the cracks within our health and social care services, and just for far too long how we've not really appreciated our key workers. So that's something we really want to see prioritized in the post-COVID world. And again, in the middle of this crisis, there's also been all sorts of innovation happening in the ways that people work. We really need to capture that learning and insight and those stories to really shape how we might transform services in the future. people for far too long were really avoidant of using digital interventions. For example, we would make up any excuse not to kind of train ourselves to do this and that. And now, you know, it's in some ways, and for some communities, making a world of a difference in terms of access to support. So there are, you know, those kind of pockets of good practice and good work that's happening that we can definitely carry forward.
Thank you, Kadra. I think we have to wrap it up here. Apologies to anyone else who was sitting on burning questions. Please type them into the chat, and we will obviously summarize all your questions also and share them with Kevin, and we will also go through them and make sure Kadra is aware of anything you're saying vis-a-vis her. I think there was someone else who wanted to sign up to your open letter, for example, Rebecca from SignHealth. The more of these connections we make, the stronger we will be. And I'm going to hand over now to Jess, who is opening up another opportunity really to make some of these connections, because we are planning a big conference in the autumn that will have an inequalities focus. Initially, we wanted to follow on from Marmot's 10-year on review, but now we're thinking this will probably have to have a distinct COVID flavor too. So Jessica will take over from me now and talk a bit about where our thinking has got to, and really ask you for help to make this as good as it can be.
Hello everyone, so I'm very excited to be able to share with you that this conference will be going ahead in the autumn, probably early September time, although we have decided it should be a digital conference, so we're going to need some help from members in making that a reality and making it a groundbreaking conference in that respect. The conference has been born out of conversations with our National Voices Inequalities Network, which if you're not a member of, you're very welcome to join. As we wanted the network not to be a talking shop, but we wanted it to have real tangible outputs and drive forward its own agenda. So as Charlotte just said, it was going to be focused on Marmot 2020, and we will still be having that report central to the conference. And we're also very pleased to be supported by the Health Foundation, who are supporting it as part of a series of events to keep the conversation going about the widening gap in healthy life expectancy and the impact of austerity on health inequalities. However, we can't ignore the situation we find ourselves in now, and obviously, as we've just been discussing, COVID has shown how quickly there can be change. It's shed light on inequalities and made a lot of things much worse, but there have also been some great things, and hopefully now there's political impetus for change. So we're going to try and be capitalising on that where we can. We also think the VCSE sector has a really important role to play in responding due to our understanding of people's real lives and the information we can then share with decision makers, but also the practical solutions we're able to put in place ourselves. So with that in mind, the conference has a twofold aims. One of which is we want to look at the practical solutions we can undertake ourselves as a sector. So we're going to be inviting charities to share the work they've been doing, the projects they've been doing, which have been successful in some ways addressing health inequalities and learning from one another and looking for areas of collaboration. And we're also going to be looking to identify issues and solutions to put to decision makers. So identifying key messages of what needs to change and what the solutions can be. In light of COVID, we'll be looking at what has worked and what hasn't, and how we can keep the good stuff and address the issues which have come up. We're going to try and be as positive as possible when engaging with decision makers. I know a lot of us might be critical about the response there has been, and we've obviously seen often firsthand the impact it's having on people's lives, but we really want to engage with people and offer them solutions and bring them into the room. So we're going to be trying to invite politicians and decision makers to take where possible. So I'm really keen to get as many members and actually non-member charities involved in the planning of and the running of and the conference itself, which might be a day or it might be a week of different events. We haven't decided yet. And I'd like to form a conference working group who will start getting together from the next couple of weeks onwards up until the conference in the autumn to plan it. I'm looking for people to join that working group to work with us on the agenda and the workshops we'll be having and potential speakers we'll invite, to plan and strategize for how we can make the conference as impactful as possible. And I'd also really appreciate anyone who's got knowledge of running digital events or has just participated in a digital event recently. You thought, you know, that's how it should be done, that's wonderful, or just have ideas to come forward and join in with that planning. So if you'd like to get involved, we'll be sharing my email address in the chat, and please just drop me an email and I'll be very grateful to hear from you. I think one last thing I'll say is you might be aware that through these webinars, we think it's really important for the whole BCSE health and care sector to be able to come together, share learning, support one another, hear from people who are running great campaigns and people making decisions. So we've adopted a policy of generous leadership, which means we're not limiting this to just National Voices members, and we want to get other charities involved. In fact, I think some of the most impactful solutions that are going on in response to health inequalities and in response to the issues COVID's thrown up are probably small local charities who are doing things with people very much on the ground and on a day-to-day basis and being born out of necessity. So we're really keen to get anyone who's doing that sort of work involved. So please reach out to me with their details or information about any initiatives you think we should know. If anyone has any initial comments, I'd be delighted to hear from them. If not,
that's wonderful. Thank you, Jess. We've had a couple of people volunteering themselves already on the chat. That's great, and we will definitely pick that up and won't let you get away with not seeing that through. I thought in retrospect it's quite interesting when Mal published his report, which was, you know, really very thorough and very, very important, that it concluded very little could be said about the impacts all of this is having on Black and minority ethnic communities because the data was so poor, and it was really just a footnote in the report. And now, with everything we know now since COVID, this seems really quite indicative of a failure of thinking that has happened over recent years about how all these different disadvantages layer on top of each other, and how we can't keep saying that we don't know how it impacts on BME communities because we haven't got the data. We can't keep saying that because it's in that data gap that people are dying. So I think we need to kind of close that loop with the Marmot discussion, which was very much focused on income inequalities. So please bear that in mind. We were kind of a little bit heartbroken that we can't make this a face-to-face conference probably, but we want to make it very inclusive, particularly to people who have ongoing health conditions, and we think people with health conditions will find it very hard to travel to a meeting in central London in the foreseeable future. What we are hearing is that won't be possible for quite some time. So we have decided to make it digital, but we are very open about what that might be like. And in order to not make it too horrible, we're even considering doing it over a course of days rather than doing it all in one day. Right, I'm kind of swimming blind here a little bit, sorry, but I don't know whether Rebecca is on the call, who is our head of policy, who was going to talk now about future webinars.
Yes, I'm right here. Okay. Hi, everyone.
Wonderful. Very
Thank you all
what are we planning
for joining us. Yes, okay, so I've just been asked to talk about future webinars and also because I'm the new head of policy at National Voices, just to share a little bit about my own interest and approach to health inequalities. So in regards to the upcoming webinars, first we just want to reassure you all that we are going to continue to be very responsive each week in terms of what we discuss, and we'll obviously refer back to questions that have come up from the week before. And if there are any particular issues that you really want to be the focus of webinar, please get in touch with us so that we can explore that together. But at the same time, we wanted to give a bit more focus to the webinars. And so we've selected some topics for the next 5 or 6 weeks that have partly come up in past webinars or that you've already told us matter to you and that we think would be useful to discuss. So I'm just going to talk you through those. And if you have any suggestions in relation to any of these, for speakers or particular questions that you want us to address, or just broader feedback about the sort of format of our webinars, if you want more time for discussion and Q&A, or something that you'd like us to talk more or less about, please let us know. So next Wednesday, we have a webinar about care in the time of COVID with original research that's being produced by Traverse. And it will focus on why people are not using services at the moment. And we'll also tell you more about the Our COVID Voices platform, which Charlotte mentioned at the beginning today, which is a web platform that we're launching next week to enable people to share their own personal stories through written testimonies and through video accounts of how they're experiencing this crisis. Then it's bank holiday next Friday, so we won't have a webinar, but the following week, we're going to be looking at funding the charity sector in a time of increased need and economic decline, which very much follows on from some of the things that you've been raising in the chat today and that are so important. And we'll hear from Sarah Vibert from NCVO about the work that they're doing and the funding that is available. Then we wanted to have a webinar about food insecurity and anxiety. So we'll look at a range of food-related issues, access to food for people who are shielding, concerns that people have about food security, and then a sort of a more mental health slant to this as well, about the impact of this environment where people are talking about scarcity and the collapse of food supply chains and people are stockpiling on people who already have pre-existing eating disorders, or perhaps it's triggered eating disorders in people for the first time. So we'll look at that. Then we want to think about long-term conditions in relation to leaving lockdown, really bringing together health and care charities to discuss the issues that matter to you, hopefully to agree upon some shared priorities, not the least of which is the absolutely essential need for proper public engagement around any plans to lift lockdown, so we don't wind up in a situation where sort of the young, healthy and wealthy are free to enjoy the new normal, and then a whole group of other people are sort of kept in perpetual extreme self-isolation. So we want to make sure that it doesn't happen and that nothing about us without us. And then finally, we want to talk about whether or not COVID is widening the digital divide, because obviously this sort of almost overnight switch to sort of online GP appointments by video link for many people will be very convenient, accessible. But for others, it actually creates a huge barrier to receiving health and social care. So we thought we'd talk about that as well. So that's what we've got planned. Very briefly, because my colleagues thought you would be interested, my own approach to inequalities, well, essentially, inequalities has infused all the work that I've done in health policy across my academic life and in the voluntary sector. I do not shy away from asking extremely controversial, uncomfortable questions. In my academic work, I've asked about ethnic discrimination in access to reproductive health services in Israel. I've asked about sex discrimination in relation to protections given to female, male, and intersex children around genital cutting. So I'm someone who's very much up for having difficult and really important conversations. In my previous voluntary sector roles, I've led research with NHS England on barriers to access to perinatal mental health services that have affected particular groups. And in work that I've done at the Maternity Voices Partnership at Chelsea and Westminster NHS Foundation Trust, I've also thought long and hard about how to include and elevate voices from the BAME community, because as many of you may already know, Black women are 5 times more likely to die in the perinatal period. So I've been thinking about issues around disproportionate my entire professional life, and they're very much in the forefront of my mind as I take on this role. So I suppose all I want to say is that, leading on what Kadra was saying, that all you are privileged to these issues and make this really a positive moment of transformation and not one of exacerbating existing health inequalities. And that's what I'm going to be trying to do in my role as Head of Policy at National Voices. Thank you.
Thank you, Rebecca. I've given your email address just now on the chat in case any one of you have evidence or arguments you think we should include in our submissions to select committee inquiries, one about wider health needs that aren't just COVID health needs, and one about the impact of COVID on the VCSE. So please do contact Rebecca with anything you think we should know about. This just leaves me about, we're over time, I'm sorry, 1 more minute to say thank you to all of you for attending. We could have spent half an hour more today, and we would have still only really scratched the surface of these issues. This is the beginning of a conversation. We are here to continue it. We want to stand alongside your work and the insight you have. It would be wonderful if you could tune in next week into our work as we launch our COVID Voices, which will enable everyone to tell their stories and their experiences of how life under COVID unfolds for them. And we're not doing anyone a service if this is very limited and very undiverse in the group of people we reach. So if you could take this offer to your communities and the people you live and work alongside with, then we can ensure that this platform will capture a wide range of experience, including experiences of people who are affected by inequalities. So we will start loads of communication on that next week. The website is ourcovidvoices.co.uk. It's not live yet. It'll go live over the weekend. And we look forward to collaborating with you on that and on everything else we've talked about today. Thank you so much from the National Voices team. Have a good weekend when it comes, and stay safe. Bye-bye.
Thanks, everyone. Bye.